Everyone, we're running about 10 minutes late, and we will try to get started at 1 o'clock. But I think given that we have Rick and Arnold here, maybe I'll open the floor to maybe 1 or 2 questions, if you have it, and then we'll break for lunch, because I don't want us to run over too much. Everybody's hungry. Peter.
Yeah, question for Rick. We often hear of this sort of high-tech solutions that are going to radically change the way we diagnose diseases remotely or more quickly. How far away are we, in your opinion, from some of these revolutionary strategies of, moving towards the triquarter where we wave a wand and we find out if flu's in the house? I mean, how long is it really going to take to get to some of those solutions?
It's been a stage-wise process for a number of years. So we've had a lot of luck in building centralized laboratories and big public health centers and hospital laboratories, and pushing those down to regional laboratories, pushing those down into smaller units in minute clinics and mobile pharmacies even now. The next step has been pushing those diagnostics into the home. So there's lots of concern, and it depends on the disease, it depends on the outbreak or the organism as well. When we focus on influenza, a lot of concern about what an individual would do with a false positive or a false negative. And what we're trying to encourage individuals to do is take action, responsible action to reduce the transmission and to seek earlier treatment with an antiviral drug. So we look at the risk benefit of the actual testing in the home and getting a false positive and getting antiviral treatment when you didn't need it. The downside of that, would it be encouraging or promoting antiviral resistance of some sort, or would it be utilizing limited supplies of a therapeutic in the context of a pandemic or so? But looking at all of those and working very closely now with the FDA, the technology is there to miniaturize the molecular technologies to an affordable home-based system. And there's about 6 of these already in clinical studies being utilized for influenza, for hormonal changes, for fitness tests, a number of lifestyle things as well that you can monitor molecularly or in other methods. And so putting that into the home, the challenge becomes then, how do you tether that to a healthcare provider still? So we still believe that it's important when an individual gets a signal that they seek health intervention and healthcare intervention as well. We're not encouraging over-the-counter use of an antiviral drug at this point, but we are saying we should have some passive notification so that information from the indicator can be coupled to a larger community database of healthcare. So those technologies are there. And so the next step from those home technologies, and I think several of those will be approved, CLIA waived, or those devices in the next year or two. The next step is the wearables. So the technology for the wearables has come a long way. So I'm not even talking about the sophisticated things as the Apple Watch and the Fitbit that's monitoring your steps and now your heart rate and your blood pressure. And, moving those technologies, or some of those less invasive, more affordable technologies to monitor oxygen saturation, respiratory rates, body temperature is already done. So the challenge now is looking at the regulatory pathway for identifying the appropriate biometrics that can be coupled with either an in-home test or some other intervention or test between the individual's home and the doctor's office, and couple that device. So I don't know if it's necessarily a tricorder, but there are inks, there are tattoos, there are bandages, there are stamps, there are watches, there are rings, there are earrings, there are earplugs, there are everything out there today that's measuring all sorts of interesting but useless stuff. And that interesting and useless stuff is motivating people to change their behaviors. And that's what we want in an outbreak, is we want something that would indicate and motivate people to change their behavior, because they become a block and a barrier in that transmission. So it's not far away.
Okay, so before we break for lunch, any more, Suri?
Thanks very much to you both for really fascinating presentations. I think one of the themes that came up in both presentations was this concept of layering. And I think in a country like the United States, or for a pathogen like influenza, where we have a fair amount of understanding, a relatively good level of technological development, you can layer, right? You can have 4 or 5 different kinds of strategies and you implement them all at once. But we have pathogens, we have outbreaks, we have countries where it's just not practical to implement everything at once and to have that beautiful flattening of the curve. And so I'm wondering whether in the model or to Professor Monto, I mean, based on your own understanding of outbreaks of the last 100 years, are there priorities? Would you say A plus B is better, more synergistic than B plus C or C plus D? Or how do we prioritize if we don't have the luxury of 5 layers of interventions?
Mm-hmm. And it's really nice that you recognize that this model looks elegant when everything's layered in the U.S. We seem to have lots of capabilities and knowledge. We still don't layer that in the U.S. So that layering requires a lot of coordination, a lot of preparation at the individual level all the way up to the federal level, and that coordination in the messaging, when to do what and why and how. The concept of thinking about the community mitigation as well as the individual mitigation isn't well accepted out there and isn't well coordinated still, even in a very developed country as the U.S. But I would say the priority, especially in the context of a novel thing emerging, is going to be your non-pharmaceutical interventions. It's going to be knowing what and when to do it. And that is what Dr. Monto indicated. There's not a strong data set, and individuals want to take action, but they want it supported by data. Even and the messaging has to be supported by data as well, because they want to trust that they're being told to do something, and that something is going to have an impact. And so the simplicity of washing your hands does a tremendous amount in reducing transmission. And even thinking about respiratory protection and thinking about masks and respirators, as we're now trying to reimagine respiratory protection that hasn't been changed pretty much over the last 50 to 100 years either. But the best improvement in respiratory protection might still be hand sanitation. We're finding it a lot, because we can wear masks, but we do take them on and off. And in the context of taking them on and off, we're still spreading that virus or organism from our hands to our face. And that's where we're getting infected. So the coupling and the layering of the non-pharmaceutical intervention and understanding the context of each of those actions and behaviors, I think, is probably the highest priority.
And you may not need to layer as much for other agents compared to influenza. If there is nosocomial transmission as a major site of spread, such as with SARS, if there is mosquito-borne transmission, there are other interventions that are useful. Influenza is tough. It has a relatively short incubation period. It spreads person to person. There are a lot of susceptibles in the population. There's inapparent infection, all sorts of things that make influenza complicated. Some of these other infections are fortunately a little easier to address, not simple in terms of the least developed countries and low-income countries which don't have the resources. But if there is a group that's ready to go in and help with some of these interventions, that may be a strategy.
Thanks, both. Okay, everyone, I think we should take a break for lunch. Ceci or Ayano, can I ask you?
For our speakers and 4 members, will meeting 1 hour.
Okay, so there's a room for speakers and forum members in the cafeteria upstairs. And everyone, could we try to meet here, say, by 10 minutes past 1? Is that okay? That'll give everybody a little bit under an hour, but hopefully enough time for lunch. Okay, thank you.